We're going to try this really quick. It sounds like sound's coming in this time. My first time I didn't want to record, so we're going to give this a whirl. So good morning. We're going to talk about vestibular examination today. The big thing that I want to touch base with before we do a lot of talking about vestibular is just which category it falls in when we think about movement system diagnoses. So any kind of vestibular disorder that we're talking about, we're going to be thinking that it's falling under the sensory selection and weighting deficit. You can see here unilateral vestibular loss, bilateral vestibular loss, BPPV, which we'll be talking about. All of our vestibular diagnoses tend to fall underneath this category. Okay, so whenever we're talking about vestibular, I want you to be thinking about sensory selection and weighting deficit as far as your movement category. So let's go ahead and dive in really quick. We're just going to do a brief overview of history taking. What are some key things that we want to think about when we're talking with someone who has got vestibular dysfunction? So key things that we want to be thinking about, obviously we want to get a good history. We want to know what their present illness is, description of their symptoms, any precipitating factors, associated symptoms, temporal factors, past medical history, and medications. And we're going to get into each one of those here a little bit more. So when we think about symptom description, let's see if I can move this guy a little bit so he's not right in front of our thing there. But when we think about symptom description, we think about how the patients describe their symptoms, and we want to make note of the words that they use. I'm going to try not to put words into their mouth, but we may have to ask some clarifying questions with them when they give us the answers. So, for example, a lot of people are going to come into and they're going to say, hey, I'm dizzy. And dizzy can mean a whole bunch of different things to different people. So we do need to clarify a little bit more about that. So, when you say you're dizzy, what does that mean? Do you feel like the room is spinning? Do you yourself feel like you're spinning? Do you feel lightheaded, off balance? Some people will talk about having a fullness in the front of their head. So there's a lot of different ways to describe it. So you want to get at that a little bit more so you can get a better description of what dizziness means to them, because different types of descriptions may lead you down different paths as for differential diagnosis. You also want to know what provokes their symptoms. Is it movement related? So common provoking factors might be a position change. So it could be from sit to stand. It could be from laying down to sitting up. It might be a head position change. It could be walking in open spaces, moving in the environment when it's dark, etc. So we want to get in and figure out what are those things that are commonly provoking factors for them. You also want to know if they have any associated symptoms. Does anything precede the onset of dizziness? Do they have visual auras, sweating, neck pain? Obviously, when we think about visual auras, a lot of times we might think of migraines, and you can have vestibular migraines. So knowing, are there any symptoms that precede is helpful for us to know. And then if there's anything else that does occur with the dizziness, do they get nauseous? Do they have any hearing loss, tinnitus? Any falls, transient neurological signs. So those would be more associated symptoms to the dizziness that they're complaining about. Then we want to look at temporal factors. So symptom latency, the time from when they do whatever it is, the activity, to the time that they actually get the onset of symptoms. So I turn my head and I get dizzy immediately, or it takes about 5 to 10 seconds before the dizziness comes on. So how long does it take after doing the activity before you stimulate the symptoms? Symptom duration, how long do those symptoms last? Is it seconds? Is it minutes? Is it hours? Is it days? We want to categorize those things because those are all going to help us with our differential diagnosis. And then symptom frequency. How often are these symptoms happening? We want to get a good past medical history. We want to know if there's been any trauma. Trauma, a lot of times we're going to think, is there anything central in nature? Do they have any head injury type thing? Or we want to also be thinking about possibly BPPV with trauma. Is there any surgical history? So any surgical history that may impact, in the ear, nose, throat area. We're going to want to know that. Sometimes when they have surgical history, they may be on particular antibiotics, which can also be ototoxic. So getting those kind of information is good to have. And then other pathologies or impairments. Do they have anxiety? Do they have migraines? Do they have a heart history? Blood pressure issues? Those are all things that can lead to dizziness as well. So just because somebody comes in with dizziness may or may not be related to vestibular. So we're going to have to sort those things out and be able to differentially diagnose. Getting family history. Do they have history of migraines, BPPV, Meniere's disease? Meniere's disease is usually considered that it's can be hereditary. So knowing some of those factors would help to kind of guide us and have that information as we're going through our differential diagnosis. And then we also want to think about medications because there are certain medications that are going to impact dizziness. So if somebody's on anti-anxiety or a sedative, basically it's going to slow down the central nervous system. So they're not going to react as quickly, and it's going to diminish what their symptoms feel like. So they may not be giving you the truth as to how flared up they are or how bad their symptoms are. We also want to think about if they're on antihypertensives, okay, because we could have orthostatic hypotension, which might be causing some of their complaints of dizziness. And then if they're on any diuretics, or if they're on any antibiotics that are ototoxic, okay? So gentamicin would be a big one. That's toxic to vestibular hair cells. And so it'll actually kill the hair cells, and hair cells don't grow back. So if we start losing hair cells, we're going to start losing the ability to be able to assess stimuli as it comes in and out. So it is going to impact our vestibular system's ability to function. And then also diuretics, things like that may also change blood pressure as well. Okay, so then we're going to move into systems review. So once again, these are going to be questions that we're going to ask them. We're not actually going to go ahead and test things, but these are the questions that we want to look at in our patient interview that we want to check as far as symptoms go, because there are multiple different systems that could make somebody feel like they're having balance deficits or dizziness. So we want to definitely get a good cardiovascular check as far as that goes. Blood pressure obviously is going to be a huge thing that can impact whether or not a patient feels dizzy or not. I'm going to look at integumentary. So if we're noticing that they're having different areas where they're all marked up, are they getting bruised? Are they falling in certain areas? We might be able to identify they're falling a certain way, even if they can't tell us those things from all the bruises that they have. Also, if they're diabetic, that's going to obviously impact skin changes, and that's also going to impact sensation, which could also lead to issues with balance. Musculoskeletal, it's going to be your normal stuff. You still want to know, is there anything cervical that's going on, because you can have cervicogenic dizziness. So we want to make sure that we're knowing if there's anything else that's going on musculoskeletal wise. As well as neuromuscular, if they do have weakness, sensation deficits, things like that, that are more neural related, we're going to need to know those kind of things too, as part to tease things out and where the symptoms are coming from. Always good to look at GIGU. If they have issues with, incontinence, it might make them hurry to go to the bathroom, etc., which might end up causing issues with them with falling. So it's just getting to know some of these things and making sure we're clearing all the systems. Cognition, communication, and affect. Obviously, if there's any safety awareness deficits, judgment, those are things that could impact their ability for falls and balance as well. And then we also would look at metabolic. All right. So once again, I've kind of touched on most of these as far as they go. So the slides are just kind of repeating some of the things that I'm talking about. That could impact their balance. Okay. Then we do have a few questionnaires. So if you're doing your want to learn a little bit more about how the dizziness is impacting them, you can go ahead and give them a few different questionnaires that they can fill out prior to treating them. So we have a verbal analog scale, which would be the simple, 1 to 10, 0 to 10. How bad is your dizziness today? 10 being the worst, 0 being no dizziness whatsoever. There's a dizziness handicap inventory, which we'll talk about in a second. There's the vestibular disorders, activities of daily living, VIDA, I think is what they call it. And then there's also the activities balance confidence scale, which is the ABCs, which you guys should have learned, I believe, this year and last year as well in CP. So really quickly, here's just that verbal analog scale, 0 to 10. Dizziness handicap inventory. This is probably one of the bigger ones that's used out there. It's a 25-item test, and it assesses the self's perceived handicap to dizziness. So the higher the number, the bigger the impairment. So it's scored out of 100. So if you're closer to 100, you're going to have a bigger impairment. Sorry about that. Okay, so VADL, so the vestibular disorders, activities of daily living. This once again it's the patient's assessing the self-perceived disability that they have. So once again, the higher the score, the more disabled they are. And they look at 27 different activities of daily living. There should be links that you guys will be able to look at each one of these tests as well. Okay, and then the ABCs, you guys have seen this before. The only difference with the ABCs is that the higher the score, the greater the confidence, meaning the less risk for falls that they have. So a higher number indicates that they are functioning better versus the other two scales. The higher the number, the more severe the impairment. Okay, so we just visited this a little bit ago with concussion, and we did our oculomotor exam. We've already talked about spontaneous nystagmus, the H test, the cover-uncover test of skew, saccadic eye movements, and then we also have static and dynamic visual acuity, VOR cancellation, and the head impulse tests. And the ones that we will be focusing on lab coming up is going to be the Dix-Hallpike and the roll test. Those are going to be looking specifically for BPPV. Okay, so we want to make sure we're doing a complete oculomotor examination. So we may not do every single one of those tests, but we do want to look at and figuring out which ones do we need to do to help rule in a certain diagnosis and rule out different diagnoses. So, but I would tell you on everybody, you should almost always do a Dix-Hallpike in everybody, unless for some reason you have a contraindication to not do that when somebody comes in with complaints of dizziness. BPPV can be masked in a lot of different ways, and it's a very simple test that really shouldn't impact your patient as long as it's not contraindicated. So I highly recommend that you do it on every single one of your patients that come in with dizziness. But once you've gotten your oculomotor, that hopefully is going to help us at least figure out where the dizziness is coming from and work on our differential diagnosis so that we'll be able to determine whether it's a peripheral deficit, whether it is central in nature, or whether it is BPPV. And so hopefully we'll get all that out of our oculomotor. But we can't forget about the fact that the person still is going to have their function impacted based on the vestibular dysfunction that they're having or the hypofunction that's occurring. So we still want to look at their stance as well as their gait. So we're going to look at balance. We may do things such as Romberg, sharpened Romberg, obviously gait analysis, tandem gait. DGIs are usually really great. FGAs, because they add the vestibular component of the head turns and everything, even your mini best. So those would all be great tests to think about when you're looking at somebody with a vestibular disorder. As we've talked about in concussion, you would have seen the neurocom and the computerized dynamic posturography, so the sensory organization tests and some of the other tests that can be done with that. So this is a great way to capture things as well, to see once if the vestibular system is impacted, because they can actually put you in positions that look highly on the use of your vestibular system and whether it's functioning appropriately or not. Okay. Now, you guys would not do ENGs or anything like that, but a lot of times if they're sent to the ENT, you might get a reading or report back from an ENG, and really what they do is they're going to hook up electrodes and everything, and they are looking at oculomotor testing, positional testing, and caloric testing. So the big thing that I take out of my ENGs is if they have caloric testing done, and usually there's an abnormality if there's greater than a 25% difference between each ear. So a lot of times it'll come in and say that there was a 25% weakness in the right ear compared to the left. So a lot of times that's really helpful for me when I'm looking at hypofunctions to see how great of a hypofunction they're having, a deficit from side to side. And the other big thing that I want to point out about when you're doing your vestibular examinations is to remember when do we need to refer to a doctor versus us continuing to treat, or what needs to be done. But things that you want to be paying attention to that might warrant a referral would be sudden or unexplained unilateral hearing loss, unexplained neurological signs. Obviously, if this is something that's already in their diagnosis, we're not going to be as concerned with it. But if you're seeing central signs or other neurological signs that don't line up with the diagnosis and the reasons that they're coming in, you'd want to refer them out to someone to have that looked at further. Inconsistencies in the clinical exam of vestibular dysfunction, history, physical exam. So if it's not all fitting together and seeming like it makes sense from what we've known, what we've learned, then it may warrant a further referral somewhere else to dig into some other things to see what the main cause of the vestibular dysfunction is. And the exam doesn't reveal the cause of the patient's problem. If you do everything and you are not eliciting their symptoms whatsoever, you can't provoke them, can't make them better, can't make them worse, then you have to question whether or not it's a vestibular in nature, because what we're doing to our testing to try to assess it and elicit it is not coming on. So, and the other thing, you'd always want to refer back if you don't see any improvement after 30 days. Okay, and that is the end of this recording, talking just about the different components of the vestibular examination. We'll get a chance to put it into play in cases in the next class.